And today's topic is on immune thrombocytopenia. So the name itself suggests immune thrombocytopenic purpura. Earlier it is called as ITP, which stands for immune thrombocytopenic purpura. The name itself suggests there is some immune activity which results in thrombocytopenia or which results in decreased platelet. So what happens? The platelet is bound by some antibody. This platelet coated with antibodies are destroyed by cells of mononuclear phagocytic system in the spleen, which results in decrease in platelet. So the platelet are coated by antibody which are taken to the spleen and thus they are destroyed there, which results in thrombocytopenia or decreased platelet count. The antibody binds to the platelet receptors like GP1b/9, GP2b/3a and then taken up to the spleen for sequestration. Thus the lifespan of the platelet is reduced to 2 days. Normal lifespan is from 8 to 10 days. We have two types of ITP or immune thrombocytopenia. One is acute, another is chronic. So now we'll see what is acute ITP. It is self-limiting. That means it recovers within 6 months. There is no need of treatment. It occurs in children usually 2 to 6 years of age. There is prior history of viral infections like measles, rubella, EBV, etc. There will be symptoms like bleeding from gums or nose, that is epistaxis or ecchymosis. All those are the symptoms of acute ITP. Now if you see the peripheral blood smear, you will see low hemoglobin because there is thrombocytopenia, that is decreased platelet. So there will be bleeding which results in loss of blood, which results in low hemoglobin or anemia. Thus you can see low hemoglobin and platelet will also be reduced, and also you will see giant platelets. There are slightly bigger platelets and the platelet count is usually 40,000 to 5,000 on peripheral smear. If you take the bone marrow, so usually we do bone marrow in order to rule out acute leukemia. So bone marrow is must to rule out acute leukemia, and it should be done before the treatment with steroids. So under bone marrow what you will see, there is megakaryocytic hyperplasia. There is increase in megakaryocytic series in the bone marrow, and there are immature megakaryocytes because there are large number of pro-megakaryocytes. This is due to thrombopoietin induce early release of functional large platelets. So there is as a compensatory mechanism, thrombopoietin will stimulate the bone marrow, so there is more and more production of platelet or megakaryocytes, which results in more number of pro-megakaryocytes. If you take up individual megakaryocyte, they have smooth border. In contrast to normal, there will be blebbing or budding is seen. From these bleeding, small platelets are produced, but in this case the border is smooth. There is no budding and the cytoplasm is basophilic. This is the individual morphology of the megakaryocytes you see. Now coming to the treatment part. Treatment is given, as I told you, within 6 months there is spontaneous remission is seen, but treatment is given when it is less than 20,000 because there is chances of intracranial bleeding. In that case we go for steroid or intravenous immunoglobulin. Compared to prednisolone, intravenous immunoglobulin, there is faster increase in platelet count. You call it as persistent ITP when even after treatment this persists for more than 3 to 12 months. Now coming to chronic ITP, so here the thrombocytopenia persists more than 12 months, unlike acute ITP where remission occurs within 6 months and it is insidious in onset. It occurs more commonly in adults. Female are 3 times more commonly seen in male. And you will see epistaxis, you will see petechiae, hematuria, ecchymosis and other spontaneous bruising, and in young female you will see menorrhagia. Here also antibody coated to platelets sequestered in the spleen, and also these antibodies will suppress the megakaryopoiesis also. So there is overall decrease in platelet production, and whatever the platelet is produced are getting destroyed, so there is low platelet, hence thrombocytopenia. If you take up the blood findings, platelet is around 10,000 to 50,000, and you will see large platelets, and mean platelet volume is increased, platelet distribution width is increased, that is, there is variation in the size of the platelets. So platelet distribution width is increased, bleeding time is prolonged, whereas PT, APTT are normal because coagulation factors are not affected, only platelet is reduced. If you take up bone marrow, it is not diagnostic, but you have to rule out other causes of secondary thrombocytopenia. The other causes of secondary thrombocytopenia are TTPs, hypersplenism, myelodysplastic syndrome, or it could be acute leukemia or heparin-induced thrombocytopenia, or artifactual clumping of platelet due to EDTA. Sometimes the EDTA sample, if you run in the counter, there is low platelet. But if you do the smear, you will see normal platelet because platelets will be in clumps, and also because of platelet agglutinins or platelet satellitism. You have to rule out what is platelet satellitism, in which WBC are surrounded by platelets. Okay, platelets present on the surface of WBC are known as platelet satellitism. So you have to rule out all the secondary causes of thrombocytopenia. For that you need bone marrow and peripheral study, then you can diagnose ITP. Again, you will see megakaryocytic hyperplasia, you will see more of pro-megakaryocytes, and as I told you, there will be smooth powder, there is no budding, no formation of platelets from these budding, hence it is termed as non-functional megakaryocytes. And if you see the nucleus are non-lobulated cytoplasm, again they are basophilic, there is no azurophilic granules, few vacuolations are seen. So surface is smooth, no budding, nucleus is non-lobulated, there is no lobule, cytoplasm is basophilic and no granules are seen, and few vacuolations are also seen. So this is about, in bone marrow you have to talk about megakaryocytic series, myelopoiesis, that is myelocyte series will be normal, it is not affected, and you have to talk about erythroid series. So in some cases there is normoblastic hyperplasia because of bleeding there is anemia which results in hyperplasia of the normoblast for the compensatory production. So there is something known as Eevan Syndrome, where you have autoimmune hemolytic anemia and immune thrombocytopenic purpura, wherein antibody is produced against both RBCs and platelets. So there is decreased RBC, there is platelet. So there is autoimmune hemolytic anemia and immune thrombocytopenic purpura. This is termed as Eevan Syndrome. Thus I told you the diagnosis is always diagnosis of exclusion. Now coming to the management, suppose the patient platelet is more than 60,000, then no treatment is required, just the follow-up of the platelet count. Suppose there is less than 50,000 with significant mucosal bleeding, or the platelet is less than 20,000, in that case active treatment is required. So the treatment with steroids, intravenous immunoglobulins or other immunosuppressors are given. Now there is no response to steroids, okay, and the platelet count is less than 10,000, then you go for splenectomy. Now there is again no response to splenectomy. This is termed as refractory thrombocytopenia or refractory ITP. So now I told you response, failure to response. What is this? So you call it as complete response when after treatment the platelet comes to more than 1 lakh. This is complete response. When you call it a response to treatment when it is between 30,000 to 10,000, or from the baseline count. Suppose the patient has 20,000 platelet, there is doubling of the baseline count, there is 40k like this. So doubling of the baseline or the platelet between 30,000 to 1 lakh, then it is termed as response. When you call failure or no response when platelet is still below 30,000 or less than doubling of the baseline count. What are the second line of treatment? It is rituximab, which is an anti-CD20 antibody. Suppose there is failure of first and second line treatment, then you go for thrombopoietin receptor agonist. The example for this is romiplastim. The drawback here is it is quite expensive when compared to the first and second line treatment. Now, just to sum up, acute ITP occurs in children between 2 to 6 years, whereas chronic ITP occurs in adults between 20 to 40 years, and chronic ITP most commonly occurs in female, that is 3 times more common in female, and there is history of antecedent infection in case of acute ITP, like various viral infections, and platelet count goes below 20,000 in case of acute ITP more commonly. And onset is abrupt, whereas it is insidious in chronic ITP, and duration is 6 months. I told you after 6 months the remission occurs, but in chronic ITP it lasts for months to years together, and remission occurs in 90% of the cases, and treatment is not required in case of acute ITPs, whereas requires treatment in case of chronic, and the prognosis is comparatively good in acute ITP when compared to the chronic ITP. Thank you.